Good afternoon, everyone, and thanks very much for joining us. You may know that there's been a fair bit of attention today in relation to overdose as a result of the overdose report that is the topic of this conversation. So really pleased that we've got so many people joining us online. I firstly wanted to welcome you all to this seminar, but to also acknowledge the traditional owners of the land on which I am currently. I'm sure we're all on various traditional lands. I'm on the lands of the Wurundjeri people of the Kulin Nations in Melbourne, and would like to acknowledge elders past, present and future, and also welcome any First Nations people in the audience today. We've got a terrible toll in relation to First Nations overdose, actually, which is part of the reason that I'm really pleased that Scott Wilson is going to speak with us on those issues. Scott's well, you know, to be honest, he's a long-term board member of Penington Institute, so he's provided strategic advice to Penington Institute for a very long time, but his contribution to my mind in Australia is absolutely enormous. He's been driving the Aboriginal Drug and Alcohol Council of South Australia for a very long time as the CEO, but he was there at the beginning of the Australian National Council on Drugs, and, you know, played a really key role in the introduction of the diversion initiative back 24 years ago. But he's been I guess had the ear of government and the ear of community organisations for a very long time, and he's currently a council member of the National Aboriginal and Torres Strait Islander Health Council. He's very mixed up in the voice policy design and implementation of the campaign, so he's central to the voice. I guess that's slightly outside of our topic today specifically, but it's an absolutely sort of an essential element of the work that he's been doing, contributing to an improvement in the health and well-being of First Nations people. So I'm really pleased that Scott's going to address us, and that Scott will be followed by Dr Karen Gelb, who's the Manager of Research and Workforce Development at Penington Institute, and has been working in criminology for a very long time, including in government and lecturing at university, etc., but has been doing the overdose report for Penington Institute for the most recent years. I think we're in our 8th year now, and so I think the last 3 years Karen has led it, but contributed to it in the year or two before that, so has been really right across the overdose report. And I should have actually said at the very beginning of this that my name is John Ryan. I'm the CEO of Penington Institute. We're the conveners of International Overdose Awareness Day, and this seminar is really in the lead up to International Overdose Awareness Day, which did start in Melbourne and has grown legs and acknowledged as a key overdose campaign, overdose prevention campaign in many jurisdictions around the world. I went to a barbecue earlier today in Collingwood, which sort of poetically was exactly what the first overdose day in St Kilda, organised by Sally Finn, a needle and syringe program worker, was 23 odd years ago, which was a barbecue to acknowledge the unspoken grief that many of us experience in relation to overdose issues. As time's gone by, we've really improved the emphasis, I think, in thinking around overdose to not only acknowledge those people that are lost, but to want to do more to prevent further unnecessary deaths from overdose. And I know there's a lot of people on this seminar that would have had personal experiences of overdose and lost members of their friends and families and neighbours. And so I think a really big shout out to all of us who suffer that grief. You know, there's 30, well, I shouldn't start talking about numbers, that's Karen's job, but it really is a massive issue that we should be facing up to as Australians without fear or favour. That's not what's happened. In terms of housekeeping for this session, Scott will speak first, and that will then be followed by Karen. We've got the opportunity to for people to ask questions. Just drop the questions in the Q&A box. There's a lot of people online, so I can't guarantee every question will get addressed, but we'll try to follow up with that outside of the session if it's feasible. The challenge is to try and pack as much into this session as possible, and I don't want to keep rambling because I am sucking up the oxygen. So we'll have a good chance, hopefully, for at least 20 minutes at the end of this session for a bit of backwards and forwards and Q&A, and I think that's it for the hour. Other than, I think it's fair to not only acknowledge everyone that's joined today, so thank you, but also to acknowledge the Penington Institute team. Like we're a very small organisation. There's only 10 of us as employees, and so it's all hands on deck for Overdose Awareness Day, for the annual Overdose report, and obviously for activities like this. So shout out to Penington Institute staff who are beavering away on these issues on a weekly basis. I think that's probably more than enough from me. So with honestly great honour, I'd really like to hand the microphone, so to speak, to Mr. Scott Wilson. Thanks, Scott.
No worries. Thanks, John. You can hear me? Yep. Okay, look, thanks for that. My name's Scott Wilson. As John said, I'm the CEO of the Aboriginal Drug and Alcohol Council. I'd like to start off by saying that I'm speaking to you from Kaurna land here in Adelaide, and I'd like to pay my respects to the Kaurna people, their elders past, present and emerging, and also to the Cultural Authority, to other Indigenous folk that may be on the webinar here today from wherever you are. Clearly, you know, it is shocking that every year, unfortunately, we seem to be having to have a national, international event on overdose and overdose rates happening all around the world. And so before we start, we'd just like to ask for a minute's silence for the thousands of Australians, but also the hundreds of thousands of people that are dying all around the world. And I suppose in the hour that we have this webinar, you know, we know that, you know, there'll be more deaths. So can we just have a minute's silence, please, to remember those people? Okay, thanks for that. Yeah, it's interesting. I was at an event this morning and they had a minute's silence at that event as well. And it just seems to go for a long time. It gives you opportunity to reflect, I suppose, on the fact, you know, that we're coming together here in Australia, but all around the world to sort of, unfortunately, remember people that have passed away. And as John sort of said, it does have a huge toll on people. And I'm surprised that, if you go right back, that, here we are still talking about something that's now has overtaken the roll toll in deaths here in Australia. And when you look at the millions of dollars and the huge amounts of campaigns that state governments and federal governments sort of invest year in and year out into try and reduce the road toll death, one's got to ask the question, why aren't people who use drugs and unfortunately pass away, why isn't the same investment put into trying to save those people's lives? Clearly, I'm here today to talk about unfortunately the widening of the gap when it comes to Aboriginal and Torres Strait Islander people. And I suppose, from somebody who's heavily involved in the International Indigenous Drug Policy Alliance, it's nothing new, because regardless of where you go in the world today, whether it's in Canada, the US, or other places where there are Indigenous folk, it seems to be the same old story that Indigenous people are dying at a faster rate than non-Indigenous for a variety of reasons, due to drug overdose or unintentional drug overdose. And I think at the moment, in 2019, when I was also doing media for Penington on the same event during International Overdose Awareness Day, the amount of Aboriginal people dying then and today is still about 4 times the gap between non-Indigenous folk. You would think that in itself is a shocking sort of statistic, the fact that we would have at least on a collective basis done something to try and close that gap. And as somebody who is involved in heavily involved in closing the gap as the lead convener for example, of the South Australian Aboriginal Community Controlled Organisation Networks, and also one of the deputy conveners for Coalition of the Peaks, which are the voices for closing the gap, that there'd be something that I could actually sort of say that we're sort of doing in addressing that. But unfortunately, drugs and things like that don't really get a mention in any of the, for example, the 17 socio-economic targets in Close the Gap, which is a great shame, and obviously is something that I continually try to advocate both on a state and a national basis to sort of have that included. It's almost like that it needs a target in its own right. It's a crisis for Australians from all walks of life, but clearly, as I said, I'm here to talk about the crisis that's confronting Indigenous communities across the country. It was in 29, Aboriginal folk had a higher rate of drug-induced death. Something like 9.5 people die per 100,000 compared to 20 deaths. So it went from 9.5 to 20, whereas for non-Indigenous folk, it's basically been about the same, around about 5.4 to 5.9. You would think that, that policymakers Australia-wide would get their acts together, because we know that access to pharmacotherapies, for example, treatment for those who seek, should be easy. And I know that we run a clean needle syringe program ourselves here at ADAC in our main office, and we were actually encouraging clients who come into the clean needle program for quite some time now to sort of make sure that they could get access to naloxone or Narcan. And then, we were pleasantly pleased when the federal government sort of made that freely available from the 1st of July. But again, unfortunately, you know, you can't get access to that at the moment because there seems to be not just a state, but a national shortage of Narcan. And one would think that if you're going to have a major national initiative and make things freely available, that you'd make sure that the supply was also there for those people that might need them. Because approximately about 12% of people on pharmacotherapies across the country are Aboriginal and Torres Strait Islander people, which clearly says that, you know, when we make up about 3% of the Australian population, for us to sort of, you know, have a rate of about 12% on pharmacotherapy basically does actually show that, you know, it's well needed out there, and to not be able to get some access to some of those sorts of life-saving sort of medicines is shocking, really. One of the things that you know, that sort of struck me just recently is that you know, they've been excluded from programs designed to promote health equity by supposedly limiting expenses for Aboriginal and Torres Strait Islander people, including in the Closing the Gap program and patients for remote area Aboriginal health services. But even after the July 23 announcement by the federal government, unfortunately, Closing the Gap coverage does not apply to pharmacotherapy medications, which means that it makes it a little bit more difficult for people who might be trying to access, you know, whether it's Suboxone or Buvidal or things like that. One of the problems for a lot of Aboriginal folk is because I don't think that the education and awareness campaigns, I haven't seen any for quite some time, are really out there around overdoses are more common for people who actually do mixed drugs, and that includes alcohol. And one would think that, you know, for a long time now, we've been sort of advocating that for a lot of our client base, they're basically polydrug using people who might be using, you know, in this case, opioid type medications or illicit opioids such as heroin, but they'll also be using other substances like alcohol. And the combination of the two, unfortunately, can lead people into a drug overdose situation. As John said at the start, unfortunately, a lot of us do experience this sort of tragedy firsthand. For example, in the last year, my own son has been in and out of ICU hospitals here in Adelaide on no less than 5 occasions where he's had an overdose situation. I would have thought that might have triggered off, you know, the hospital drug and alcohol team to sort of follow up before they left the hospital, or to provide, at least follow up once they'd left and provide them with sort of information that might actually either get them to change their behaviours or at least give them the products such as Narcan that obviously they might need, or not necessarily them, but people that they live with might be able to use to keep that person alive. Some of the other staff that we employ, unfortunately, did have loved ones who overdosed and died this year. So this, it's not just from a sort of policy or a high level sort of, you know, talk fest notion that we're talking to you. This is from obviously something that sort of affects people that I work with, people that I live with on a daily basis. And I suppose one of the wake-up calls that I know that the Penington Institute and others have sort of been calling for the Australian government and state governments to sort of be quite well aware is the sort of next wave of drugs that are sort of will be readily available, because let's face it, it starts off small and then before you know it, you know, you've got a major crisis is what's happening overseas in places like Canada, which has decimated, you know, Canadian Indian communities and also American Indian communities, is the rise of fentanyl and other drugs like that, that sort of is the next wave. I've been here for, as John said, a long time. And when I first started at ADAC, clearly the major issue was alcohol. But over the years, it's gone from alcohol to the heroin sort of crisis that we had, that some of you might remember, all of the health ministers across the country, including the federal health minister, basically called for national heroin trials, and that was sort of stopped by the then Prime Minister. So things have sort of moved, you know, fast forward to where we are today, where we still have similar situations happening with people who use drugs, but unfortunately, when it comes to federal government or state government intervention, and one of the interesting things will be to see whether any of the other jurisdictions take up the lead of the ACT and decriminalise all drugs like they did, I think it was today, as a way forward. I find it interesting that besides New South Wales and Victoria, there are no other safe injecting rooms that have been shown to keep people alive. In particular, Aboriginal and Torres Strait Islander people who do go to those places, that those are the only jurisdictions that actually have things like that. As I said, we don't look forward, but we hope that you know, by talking at events like this, that we provide you know, the federal government, who might actually be online listening, to the ways forward. As part of their Close the Gap initiative, joint implementation plan, for example, that was tabled in Parliament, federal Parliament last year, which sort of lays out all of the areas and the programs that the federal government will fund when it comes to Aboriginal and Torres Strait Islander people. They did have a $66 million fund for alcohol and other drugs. Unfortunately, they've spent a year basically workshopping on how they could actually spend that $66 million. So, you know, the year's come and gone, and we're now into another year, and that money still hasn't actually, they still haven't worked out how to spend that money. Clearly, we could tell them how, and I think we tried that on the workshops that we've been involved, but whether anybody's listening is beyond me. There is a lack of, you know, services, as some of you might recall, that when the federal government under the previous coalition decided to cut things in 2014, such as the National Indigenous Drug and Alcohol Council, that actually provided strategic advice. There's been no strategic advice really going to the federal government around drug and alcohol since then. The National Aboriginal and Torres Strait Islander Drug Strategy has nothing in there about overdose, because the last time that they actually had any community consultation was prior to the 2014. And so basically they just rebadged these national strategies by putting the, you know, another date on it. So it went from 214 to 219, and I guarantee you it's now probably got 226 on it. But nobody's actually gone back to the actual people that sort of live this on a daily basis, or either as loved ones or people that are working in this area for a hell of a long time, trying to bring about change. So one of the things that we hope is, you know, the forthcoming referendum on constitutional recognition may actually, one of the things that I'm looking forward to is somebody involved in closing the gap, is that if a state government chooses not to sort of go with the national agreement, there's nothing that actually compels them. So one would hope that with a constitutionally enshrined voice, it'll actually give the legislative hammer to be able to sort of make sure that state and territory and federal governments agree to, you know, abide by what they've agreed to in the national agreement that they've signed till 2032. So I look forward to how that sort of plays out into a positive outcome later on in the year. And thanks for listening. No worries. Goodbye.
Thanks very much, Scott. And please stay on the line so we can learn from Karen and then learn from each other in that Q&A opportunity. I briefly introduced Karen before. I just wanted to say, I possibly didn't say Dr. Karen Gelb, which is a bit of a mistake. And the other thing I didn't say, which is probably also a mistake, but I'll say it anyway. Karen's one of those few people that actually gets excited about numbers and the way that numbers actually sort of relate to each other. And that's a real gift in relation to somebody doing the overdose report. And even though the topic is incredibly, you know, serious and sober, and the dehumanizing element of actually just ending up being a number is something that we're always very conscious of. I think we really are operating on that old cliche that if you don't count it, it doesn't exist. And I think the fact is that we have been counting overdose, the overdose toll for the last 8 years in Australia in order to put up that mirror. And so we're very lucky to have Karen helping us, and Emma Richards is in the background as well in Perth, working and beavering away, supporting Karen. But over to you, Karen.
Thank you, John, for that introduction. I'm just sharing my screen here so that we can look at some of the data together. This is about Penington Institute. I think it's important that we make the point that we are non-partisan. We do not take sides. We are based on trying to promote the evidence by connecting that lived experience and the research. As John mentioned, we are also the convener of IOAD. There's a bit of information there about it, and it is really a global event. So it's worth watching this space for what's going to be happening around the world on IOAD starting on Thursday. We're going to talk very high level today about the data in the overdose report. We do have 20 years of data. We have got new data in there on non-fatal harms. It's important to realize that with some drugs, there's a vastly higher number of non-fatal harms and overdose than fatal overdose. We include data on both intentional and unintentional deaths. And for the first time this year, we have a whole section on alcohol. We know that the overdose crisis in Australia continues. There's over 2,000 drug-induced deaths in this country in 2021, and 2021 is the most recent year of data that are available through the Australian Bureau of Statistics, because they collect data from coroners around the country, and it takes a while for those data to be finalised. We're continuing to see a high proportion of deaths due to polydrug use. And we know that the national population of Australia in the last 20 years has increased 33%, but the number of unintentional drug-induced deaths has grown 71%. So the deaths are outpacing the growth of the population. We have a total now in the last 20 years of more than 37,000 drug-induced deaths. And as has been mentioned, the unintentional drug-induced deaths surpassed the road toll back in 2014, and that gap continues to widen. And while we spend an awful lot of money on road safety, we spend a lot less money on reducing drug-related harms. This is a brief overview of some of the demographic characteristics of people who have succumbed to unintentional drug-induced death. We know that deaths are not evenly distributed throughout the community. They tend to be much higher among males, among people in rural and regional settings, and among people from low socioeconomic areas. While you can see there's that the most disadvantaged areas are more likely to see overdose, it's important to say that overdose is found throughout our community in every socioeconomic stratum, and no one is immune to that. This is, as Scott mentioned, the overdose rate among Indigenous and non-Indigenous Australians, and you can see how it has increased far more rapidly amongst our Indigenous communities than amongst the non-Indigenous communities. And Scott mentioned the data there, so that we've got an increase in the Indigenous population from around 9.5 in 2009. You can see that dip there, up to about 20 per 100,000 population at this point. So that overrepresentation is increasing. And we see the overrepresentation particularly in stimulants and opioids. For example, in stimulants, in the 5 years to 2021, there were 8.5 deaths per 100,000 Aboriginal people, compared with 1.9 per 100,000 non-Indigenous people. So that's an enormous difference in the overdose rate. Overdose death continues to be driven by the pharmaceuticals, opioids, benzos, the antidepressants there. You can see that very much it is pharmaceutical drugs that are driving the overdose deaths. I will point out that if you look particularly at opioids, where we've got 765 such deaths, half of these involved pharmaceutical opioids. The other half involved illicit opioids. We know that when it comes to opioids, most of the deaths are polydrug deaths. So the most common combination of drugs in opioid deaths is opioids plus benzodiazepines. But in the 5 years to 2021, pharmaceutical opioids on their own accounted for less than 8% of unintentional drug-induced deaths involving pharmaceutical opioids. So in 2021, there were only 40 deaths involving pharmaceutical opioids on their own with no other drug type. At the same time, heroin on its own accounted for 18% of all unintentional drug-induced deaths that involved heroin. And if you look at the time series data, you can see that stimulants and benzos have become more prominent in overdose death over the past 20 years. So if you go back to 2001, stimulants were detected in 5% of unintentional deaths. But in 2021, this has gone up to 28%. So that's a huge increase in the representation of stimulants in overdose death. Similarly with benzos, they were detected in 17% of unintentional deaths in 2001, but in 2021, this had increased to 33%. You also see increases in the presence of pharmaceuticals such as the anticonvulsants and the antipsychotics over that time. And that kind of highlights the high comorbidity between drug use and mental illness. That's the end of my very brief, very quick run through of the high level data. It is a 200-odd page report, so I would encourage you all to download it. Do feel free to get in touch with me afterwards if you have questions about it. There's an awful lot of detail in there, and hopefully it'll be a fabulous resource for everyone in the field. So I'm going to stop my share screen now and hand back over to John.
Thanks very much, Karen, and thanks also, Scott. I guess, you know, if my question, to be honest, is a pretty dumb question, but I'm busting to ask, Scott, why are we so, in your view, why are we so inadequate when it comes to addressing drug use issues? Like, you were there when Prime Minister Howard was in charge. You've watched politicians, leaders come and go, ministers for health, ministers for Aboriginal affairs. We've still got a huge unaddressed issue, and it always fascinates me as to how we could be so repetitive in the way that we behave toward these issues, even though it doesn't solve our problem. That's a question to you, Scott. And I think we've lost Scott on the, I think we've frozen. I hope I'm not frozen. Yeah, it looks like we've, well, lucky him, he missed out on a curly question. Can I ask?
Yeah, well, look, I think that part of the issue is, you know, really at the end of the day, which is why we also have stigma and things like that, and seem to have all these big national strategies on reducing stigma, is because you're talking about something that's an illegal substance that's been, you know, classed as illegal. And so therefore, you know, it's not some, whereas if you go to some countries where substances like that are actually legal, or if you go to places like towns like Vienna, which I was at recently for the Controlled Narcotics Drugs Commission, you know, you can walk into a chemist there, no different than any other health-related issue, whether you're going in for your diabetes or your inhalers. You've got a script for pharmacotherapies or even, you know, just bats an eyelid. Whereas here in Australia, in the Western world, because it's an illegal, considered to be legal, we've got all these layers of, you know, hidden and things like that. And I think part of the issue is that it's moral. It's a very moral. You choose to take drugs or you choose to drink, so therefore whatever happens to you is your fault. And I think until we as a society recognise that people, yes, they might have a variety of reasons, and a lot of it could be they're self-medicating for the harms that occurred to them as they were growing up as children. You know, the whole reason why Aboriginal and Torres Strait Islander folk are still self-medicating is because intergenerational trauma. And hopefully, you know, one step forward in actually addressing that trauma is with constitutional recognition in the referendum that's coming up. We can look back in 5 years and see whether that, if that is had an impact on that. Hope that answers you.
Yeah, no, thanks. Karen, this is a question for you, and the question is data on tapentadol being collected? Tapentadol use has increased significantly over the past years, but there is much data on harm, overdose, death. Or there is not much data on harm, overdose, death.
Yeah, the tapentadol data are collected, but they're grouped under with other specific drugs as well. So we are constrained by what the ABS is able to collect from the coroners around the country. The grouping that has tapentadol in it also has fentanyl and pethidine. So it's kind of a group. We're unable to disaggregate that. And a similar situation, I see there's another question about stimulants, around stimulant-related unintentional deaths. What proportion are due to illicit stimulants and how many are due to prescribed? Again, constrained by what what the ABS can provide us. We have stimulants as a broad category. We're not able to differentiate that. That is likely to change, actually, in coming years. Under the International Classification of Diseases, version 11, there is a disaggregation of specific drugs rather than sort of grouping them together. And the ABS is in the process of moving towards using ICD-11. It currently uses ICD-10. So that's not going to be a quick process. It's a national collection, and it does take many years really for that sort of coding change to happen. But it will come, it will happen, and we will be able to differentiate within those groups.
Thanks. And yeah, I think patience is very sorely needed in this space. One of the great frustrations is the delay, partly perfectly reasonable for coroners to undertake investigations, but the way that thoroughness then delays the reporting back to the community is a real concern. And I think one of the shortcuts would be more transparent drug checking by government, so that we were quickly able to identify what's emerging in the drug market. We look way too far backwards, I think, in this work, and we are looking forward to a clean-up of the way that the data's collected so that we can get more granularity. Patients is one of the elements. Karen, can you maybe respond to the question? You mentioned ABS as a source of the data. Are there any other sources used for the fatal overdose data?
Not for the fatal data. We stick with the ABS. There's, for anyone who's worked with data and governments, there's an entire process behind it in terms of data cleaning and checking. So when the data come in, the ABS will go through very rigorous reliability checks. They have all sorts of verification kind of processes in place for all their data collections. So that really is the best source of data, even though it is 2021 data is the most recent we have. We know that it is very, very reliable and accurate. So that's the data that we focus on. And
there's another question there, which is, it's not a Dorothy Dixer, I swear to God, but the question is, hi, John and the Penington team. I'm hoping you could expand a little more about the work the team does between the annual overdose report, International Overdose Awareness Day, and how people could support the Institute's tireless work. Do you want to pick that one up, Scott?
Yeah, well, obviously from a board member perspective, I think that the work that the team does, trying to get the annual overdose report, but also making sure that International Overdose Awareness Day is worldwide, and basically don't get any funding from anybody for that. So, which I find quite amazing that Penington is not actually funded by the federal government or even some of the big foundations internationally to actually promote the work that they do on a global scale. So for them to actually do it and continue to do it is a testament, I suppose, to the great team that John and that at Penington do. But they also do other work, including, appearing or chairing, commissions and committees for the Victorian government on a regular basis and things like that. So this is just one part of the work that they do, but it actually has an enormous impact worldwide.
Thanks, Scott. And I think if I can just add one little bit, I would really encourage everyone on this call to participate in International Overdose Awareness Day. It takes a bit of effort, so apologies for that. But the whole model is decentralised, so we don't sort of dictate what you should do in your local community setting, whether that's your organisation or your neighbourhood or whatever in relation to IOAD. What we hope is that people will self-organise according to the priorities in their local area. And, you know, it's amazing how simple some things can be, like a barbecue or a memorial service, how healing that can be for people that don't get to talk about the loss that they've experienced through overdose. And then, of course, you know, education sessions around naloxone or whatever are also an absolutely key part of IOAD. So, you know, I think Scott's absolutely right. And the other opportunity that everyone's got, because it's coming up this Thursday, is to quickly put something together to show respect for the people that have gone, but also to better equip us for the future so that we have less overdoses. From somebody else, the question, probably for you, Karen, were there any notable interstate differences?
Well, WA is, again, the standout, and not in a good way. It has had the highest rate of unintentional drug-induced deaths in Australia since 2011, and it's quite a lot higher than the other states. So yes, that's an ongoing issue for that state.
Thanks, Karen. Scott, one for you. The data shows a relationship between disadvantage and overdose, and we know First Nations patients have high rates of disadvantage. Has this relationship been explored? Is this a racial issue or a disadvantage issue, or both?
Yeah, look, I think it could come down to being both. I would have thought that, you know, pharmacotherapies would definitely be on Close the Gap agenda and actually be covered when it comes to people accessing that. To find out that it's actually not, one's got to ask the question, and clearly I will be, why it isn't part of that. So, and you're right, John, like I know that places as far away from Adelaide as
Scott, I think we're losing you. I might just wait for Scott to let me jump. Sorry, Scott. I don't know if you can hear me, but you're frozen. So let's jump to a question for Karen and hope that Scott's internet, fantastic NBN linkage works. We're all very familiar with this problem. Karen, is there any data around GHB related overdoses?
Yeah, we do get data but the numbers are very low. So we've got a category in the report called succinamides, and a very long word that is difficult to pronounce, but it's essentially GHB. But there's in 2021 there were 27 unintentional drug-induced deaths. So it's the number is sufficiently low that we can't really go any further with that. We can't disaggregate it any more than, you know, can't explore it any more than that.
Thanks, Karen. And what about this question, which is a curly one because it's so jurisdictionally diverse? Is there a list of chemists that stock the free naloxone?
That is a curly one. I know in Victoria there is a list of participating pharmacies, but there's a very big caveat with that, and that is that just because a pharmacy is registered to stock naloxone does not mean that they actually stock naloxone or that they are actively participating in the program. So there may well be a list in your jurisdiction if you're not in Victoria, but I wouldn't hold it as truth of what's actually happening out there.
And I think the challenge for us is to have transparency around that data. And, you know, we all know that naloxone is a fantastic overdose reversal drug, but only if you've actually got it when you need it. And that's been the problem in terms of the scale of the rollout and the engagement with potential overdose witnesses. But I would encourage that person, if they were keen, to contact their I think every jurisdiction's got a consumer organisation except maybe South Australia. It's NTAC in the NT, but reach out to your jurisdiction or consumer organisation, because Penington Institute, but also all those consumer organisations around the country are very motivated by the lack of reasonable access to naloxone, and I'm sure they would be able to give you some great advice. Any thoughts or recommendations about the role of GPs? What might need to improve in that space? What information is critical for them? And that's a question for you, Karen.
In terms of naloxone?
No, I think it was a more general question. Just about GPs, and I guess between illicit opioids and pharmaceuticals. Just what can GPs be doing?
I think GPs need to be having conversations with their patients about safe use of really all their medications. It's not one particular medication or another. We know that pharmaceutical opioids can be problematic. We in our report can't distinguish between illicit opioids and misuse of pharmaceutical opioids. That's not something that we're able to get from the data. But I think it's and this goes back to what Scott was saying earlier, it's about the stigma that doctors should be having conversations just on a regular basis with their patients and making sure that their patients know how to use it safely, understand what polydrug use implications there might be for them and their particular medications, given that we know that the vast majority of overdose deaths happen in the context of polydrug use, and that doctors, GPs are familiar with the information, that they're familiar with recognizing overdose, and it can then impart that information to their patients.
And yeah, thanks, Karen. And I think we've released another report which has been a bit overshadowed by the overdose report, but it's about the Australian pharmacotherapy system. And one of the recommendations in that, I'd really encourage people actually to get onto the Penington Institute website and look at that report. One of the controversial for some recommendations that we make is that GPs and other medicos are not being properly remunerated for pharmacotherapy work, and that they should have an MBS item to properly reflect the time and effort that is required. But we've also recommended that nurses become much more active in prescribing, because there is such a deficit of prescribers. We need everyone with their shoulder to the wheel, and that includes nurses. So I think that's a report that we're not talking about today, but it's really important because the pharmacotherapy system is very fragile. I'm conscious of the time, and so I might just go to Scott for any closing remarks. Sorry, we missed you, Scott, when you were talking about Sejuna. I think you dropped out, but yeah, any quick closing comments? Conscious of the time. And he's frozen.
Sorry, thanks, John. Look,
back.
I just hope that, I don't know what happened, right? The technology, right? I just move forward that, somewhere down the track, these events become a thing of the past, because we actually have addressed stigma, we've addressed disadvantage, and that, we accept the fact that for some people, drug use is part of what.
And we've lost poor Scott again. I think he's having the day that I normally have with technology. So I think, conscious of the time, we'll have to wrap it up. But I do want to really thank Karen and Scott for contributing today. Massive commitment. Thank you very much. And also to the team behind, particularly Karen and Scott and myself at Penington Institute for putting this together, much appreciated. We're going to follow up with you via email to share some more information, etc., which I'd really encourage you again to look deeply at the Overdose report, think about opportunities to engage with International Overdose Awareness Day and get a message out there that all lives are valuable. And finally, have a look at that pharmacotherapy report, because it is the backbone of our system, but it's incredibly fragile and risks collapse. So on that rather dramatic end, I would like to say thanks for joining us today on this seminar, and I hope you have the best of days and the best of weeks. And you missed it, Scott, but I did thank you, and sorry for the tech issues. Thanks all. Have a good day.
Yeah, take care. Bye-bye.